Parkinson's disease is often misunderstood, seen only as a condition of tremors and old age. But behind the shaking hands lies a complex, progressive disorder that affects movement, speech, balance, and even sleep. Today, we sit down with Dr. Hooker, a consulting neurologist at Aga Khan University Hospital in Nairobi, who specializes in movement disorder. He offers us an eye-opening look into what really happens in the brain of a person living with Parkinson, from early warning signs many of us might miss to the current challenges of diagnosis and treatment here in Kenya. Dr. Hooker takes us deep into the science, the struggles, and the hopes surrounding this disease.
Dr. Juzar Hooker. I'm a consulting neurologist at the Aga Khan University Hospital in Nairobi, and I've been working here for the last 21 years or so. My special area of interest is in movement disorders. So Parkinson's disease is an interesting movement disorder because it has too much movement, shaking, and at the same time too little movement, the inability to walk normally. People get slowed in their movement, in their walking, in their talking, softer in their speech, and they become more stiff in terms of their body, in terms of their movement. And together with that, they tend to lose balance, especially as the disease progresses. So I think you asked a very interesting question about what happens to the brain in people with Parkinson's disease. And really what we know is that there is a progressive loss of brain cells, especially in certain parts of the brain, deep inside the brain, where there are melanin-containing, meaning pigment-containing brain cells. And these cells produce a lot of dopamine in the brain, which then projects to other parts of the brain. This loss of brain cells is progressive, and it is thought now that probably the loss of brain cells starts perhaps as much as 20 years before the disease manifests, very, very slowly. And obviously we have a large reserve capacity in our brains and our bodies. So initially we have no symptoms, but when the brain cells reduce to a critical mass, then we start getting symptoms. Okay. As to why this happens, nobody completely understands, but we know there is deposition of some abnormal or abnormally folded, or shall I say misfolded proteins, which clump up and which the cells then find it hard to kind of get rid of. Whether that is because of the disease or whether that is the cause of the disease is unclear. And over time, that process results in those cells degenerating, like I explained. As to why those proteins misfold, again, we do not know, but there are some associations. So, for example, we know that use of pesticides, for example, is associated with an increased risk of Parkinson's disease. Obviously, as we grow older, we have an increased risk. So there are certain things that we understand, and we know that there are some people who have certain genetic mutations or genetic risk factors that may increase their risk of Parkinson's disease. Right. So, so you're talking about before they get the disease?
Yes.
Yeah, okay. So years before people get the disease, people have now looked at these, at people who developed disease and then looked back at what symptoms they may have had, which they may not have realized were related to the disease. And also now, because we have families with genetic Parkinson's disease, people can look at those families. We know that they have the gene, but they don't have the disease, and see what symptoms they may develop. So those kinds of studies have revealed certain important symptoms. One is loss of sense of smell. So obviously, like people get COVID, they lose their sense of smell, then it comes back. That's not an issue. Yeah. But like loss of sense of smell years even before they get the disease. Mm-hmm. There is a particular type of sleep disorder which we call dream enactment disorder. When we are normally dreaming, the way we have been created, we kind of get paralyzed during our dream phase of sleep, meaning we cannot move except for the eyes. And so we can't act out of a dream. So even if you're thinking that you are fighting somebody, you can't fight anybody while you're dreaming. But in this condition, that switches off our ability to move is spoiled. And then we tend to move, and it's like we're acting out our dreams in our sleep without us knowing. So it's only the bed partner, spouse, they would know what's going on. So the other important kind of common symptom in this patient is constipation. But as you know, constipation is a very common symptom in the population, so you can't really say that everybody who gets constipation, but it is more common in people with who develop Parkinson's disease. Okay. Yeah. So Parkinson's disease is still a very clinical diagnosis. As soon as a person walks into the office, indeed sometimes even when they are in the waiting room, you can already make a diagnosis as they walk in, because they often have this particular, slightly stooped posture, difficulty moving, slowness of movement, shaking, like I said, stiffness, and a certain loss of balance, or inability to maintain balance. That is how we make a diagnosis, really, putting those symptoms together. But in terms of making a clear neurological diagnosis, it's quite a process. You listen to the story, you examine the patient, you try and look for other things that it could be. And where there is doubt, there is role for, imaging the brain, for example, with an MRI scan, or sometimes even a CT scan, and with specialized type of scanning, which we now have available here in Aga Khan, which is called a dopamine transporter SPECT scan or DAT scan. Mm-hmm. So these are supportive, but at the end of the day, it's a clinical diagnosis. And a clinical diagnosis in studies done throughout the world can be relatively accurate. It's not 100% accurate, but it's relatively accurate. At the end of the day, the only way to be 100% sure is to study the brain after a person is deceased. But obviously that is done more for research than for real life diagnosis. So that also has been now studied in different African countries, and we have even in Kenya, and we have actually a limited menu of options. So one treatment option that isn't talked about a lot is exercise and physical therapy, and it certainly has a big place in helping the symptoms, and also may have a place in slowing down the progression of the disease. Together with that, things like speech therapy, occupational therapy, psychological support, social support. But as you know, all these things are very sparse in our country. So for example, we have just a handful of speech therapists, very few physiotherapists who have experience with Parkinson's disease, very, very few occupational therapists, and as you know, our social support architecture is really very, very sparse on the ground. Psychological support is also limited. Then we come to medications. And in terms of medications, the main medication, because as I told you, the cells become less, the cells produce dopamine. The dopamine is important for the brain. The way we treat Parkinson's disease is increase the amount of dopamine in the brain or replace that dopamine or cheat the brain that it is, getting dopamine. So the main treatment is replacing the dopamine. And replacing the dopamine is done with tablets for the most part. Those tablets are available here. The supply sometimes is a problem, and occasionally you don't find a particular tablet and all. But there is the cost factor. Yeah, these tablets are expensive. The common tablet is called, the medicine is called levodopa, and the common brand that is available mostly is called Cinemet. But like I said, accessibility is a problem. And we've actually, together with our colleagues, then looked at some of the availability issues here, and it's actually work done by colleagues of ours together with us, and they've shown that actually even in pharmacies, even in cities, not many pharmacies have these medications available, and certainly as you go outside cities, the availability drops significantly. Apart from the fact that the medication is costly and for many people difficult to afford on a sustainable basis. So Parkinson's disease is considered a neurodegenerative disease, meaning that there is a degeneration of brain cells. That means there is a progressive course, meaning over time the disease progresses, the symptoms get worse, the amount of disability or difficulty participating in normal activities of life, daily, our own self-care, enjoying the normal activities of life, diminishes over time. So unfortunately, it is a progressive disease, and at the moment we have no curative treatment that can either reverse it or slow down its progression. But with the medications, we can greatly improve quality of life. Obviously, the medications over time do have some side effects, and there is a whole range of medication approaches that can be taken. There are some other treatments in which one can get infusions, either through the skin or into the intestine, but those are not generally available here. And there are procedures in which one puts electrodes into the brain and stimulates them using a pacemaker device. Other than even that is not available locally, but there are patients of ours who have had it done overseas. So there are treatments, but accessibility is an issue over time. Yeah. In several ways. So one question you asked is what happens before people have a diagnosis of Parkinson's.
Yeah.
In the preceding 2 years to diagnosis, more people are likely to have a diagnosis of depression or anxiety. So it may be that the brain changes that happen also predispose to depressive and anxiety symptoms. Secondly, if we notice ourselves slowing down, unable to do the things the way we used to be able to do, obviously it creates emotions that sometimes are strong enough to be a depressive disorder or an anxiety disorder. And as the disease progresses, depression is more common and is often part of the journey of Parkinson's disease. The other way Parkinson's disease affects mental health is it affects cognition. So people's ability to handle emotions. Some people find it difficult to control their emotions, and they may cry more easily, even when they are not particularly sad. Be more mentally rigid. So everybody calls them stubborn, yeah. But it's just that they are finding it difficult to make clear judgments, less mental flexibility, and over time it can affect memory and ability to look for words, and over many years people do get what we call a dementia, meaning that they slowly, their mental faculties deteriorate in addition to the physical deterioration. That doesn't happen in everybody, but it does happen in many people in the later stages of the disease. So Parkinson's it's almost like a family disease. It's a community disease. So it's because the person is affected and struggling with it, they're experiencing the symptoms, but the care of the person living with Parkinson's disease is often a family affair, especially in our communities, which are very family-centered, and so spouses, children, sometimes parents if they are very young, because there is a group of people who get Parkinson's at a younger age, siblings, friends, and communities get involved in looking after people living with Parkinson's disease. And in that process, obviously, a lot of people get very heavily invested, especially as the disease progresses. And some of the symptoms I've talked about actually affect even the relationships between people. So, a relationship between a person living with Parkinson's disease and their spouse can be affected by their ability to move, what happens at night in terms of the sleep-related dream enactment disorder. Somebody may stop sharing a bed because they don't want to be hit by the partner who is dreaming that they're fighting off a gang, that kind of thing. Sadly, sexual dysfunction, bladder problems, all these things can affect a lot of, and caregivers play a big role in looking after people living with Parkinson's disease, increasingly as the disease progresses, and with an increasing impact on themselves as well. Sure. So I read a lot of literature about stigma regarding Parkinson's disease, and there's no doubt there is stigma, but I think we are also, to some extent, I think, hyping it up to because I think most people these days are willing to accept a diagnosis of Parkinson's disease, but true, there is stigma, and true, in certain communities they would be considered to be bewitched or need to be prayed for, or spirits exorcised or things like that. But as a general rule, I must say that most people are willing to accept an organic diagnosis of Parkinson's disease. What becomes more of a problem is some of the mental health challenges and the cognitive challenges. Those become more of an issue to accept, because it's like the person you have known for 40 years or 50 years or 70 years has changed, you see? And that becomes, I agree, a bigger challenge. In terms of, dealing with them, I think education, in which is what you're doing today, media, in every other way, it plays a big role. And recently we had the World Parkinson's Day, and there were a lot of activities to try and, improve awareness. And
we have enough.
Yeah, so I don't think there is enough awareness, just like for most diseases or conditions people experience. Obviously, most people also think of it as an old person's problem, but we know that there are many young people affected as well. I definitely there much more needs to be done to increase awareness, but I think efforts are being made. There's a Parkinson's disease support group in Kenya, in Nairobi, as well as in Mombasa, Kisumu. I believe there's an effort being made to start one in Kilifi, and I think one other place I heard of recently. So there's a mushrooming of support groups. The government has taken an interest by providing disability support. So, one can register as a disabled person, get some tax exemptions, one would be able to bring in certain equipment one needs for say mobility or things like that, tax-free. So there are, I think there is some attempt to try and help, but I think definitely more awareness needs to. Sure. So Parkinson's disease is nobody's fault. So when one gets Parkinson's disease, it's not because you've done something wrong or somebody else has done something wrong to you. It can happen to anybody. As you know, we'd have popes and presidents and, with Parkinson's disease, and they have worked and they have lived their lives and they've contributed to society. And just because somebody has Parkinson's disease doesn't mean that contribution stops. As you know, the late Pope John Paul II, he had Parkinson's disease and continued to work for years until his demise. Yeah. So, and he contributed to society. So the fact that one has Parkinson's disease should not detract from that person's worth. And really, we should do everything as a community, medical professionals, families, communities, everybody, to try and make people feel wanted, and to enable them to continue to contribute to society in the best possible way they can.
Okay.
Thank you.
In Kenya, as in many parts of the world, the battle against Parkinson is only just beginning. But with continued education, patient support, and medical advances, there is hope that one day this silent, slow-moving theft of movement and independence can be stopped in its tracks.